We are starting with session 5, that is keynote address. And as mentioned by Dr. Vaishalideshmukh, we will be taking up Dr. Pratima Murthy, who is a director, of NIMH ANS from Bangalore. Dr. Pratima Murthy, she is a professor and head of Department of Psychiatry. She is the director of NIMHANS since June 2021, fellow of Royal College of Physicians, Glasgow. She is a consultant to prominent international agencies such as United Nations Office on Drugs and Crime, the International Labour Organization, and the World Health Organization. She has been awarded with many prestigious awards: Dr. Raja Raman State Award by Government of Karnataka, Lifetime Achievement Award from Rotary, WHO Regional Director Special Recognition Award on World on Tobacco Day 2021, a prolific author with more than 300 research publications in various international indexed journals and scientific textbooks. So with this introduction, I hand over the session to Dr. Pratima Murthy.
Thank you very much. Thank you. Yeah, so it's been obviously a very exciting day at the Synapse, and you've been having very interesting topics for discussion. What I'm going to do in this next 20 minutes is really talk about how we can address risk factors for non-communicable diseases and use telehealth, and particularly with a focus on mental health and telemental health. So we all know that, there have been so much exciting discoveries in a whole range of diseases. We know we've been interested in not just molecular mechanisms, about genetic mechanisms, about genotyping, looking at the various interventions that are possible for a variety of health conditions. But it's equally important that we also understand mental health and its various ramifications in health and disease. So I think looking at mind and body relationships has now become very important, and COVID certainly has told us the importance of the mind and how in times of stress there can be severe disturbances of the mind, which in turn can affect the body. We all know that we have in India a dual burden now. While communicable diseases are on the decline, certainly it's not gone away anywhere. And therefore, conditions like tuberculosis, hepatitis, and other conditions are still things that we are grappling with. But we also see a rise in the non-communicable diseases, which have been described as the new epidemic. And we know that the burden of NCDs is actually increasing, particularly in developing countries, and about 1 in 3 deaths occur in people below the age of 60 years. We also know that particularly in terms of hypertension, mental disorders, ischemic heart disease, diabetes, and cancer, that there is a sizable burden in the country. We know that behavioral factors are responsible for a variety of the deaths that are attributable to non-communicable diseases. And the important message is that these are all potentially preventable. So, a few years ago, the WHO, in collaboration with the Ministry of Health and Family Welfare, Government of India, brought out a series of manuals to train counselors, medical officers, as well as community health workers in trying to reduce risk factors for non-communicable diseases in primary care. And these are available online for any of you who might be interested. So when you talk about risk factors, we know that that's a factor which increases the risk or hampers recovery or complicates recovery from non-communicable diseases. And we know that there may be non-modifiable factors, particularly age, gender, and a family history, which imposes a genetic risk on these NCDs. But at the same time, you'll see that there are certainly a larger number of modifiable risk factors, and we need to pay more attention to these modifiable risk factors, whether it's tobacco use, indoor air pollution, the use of alcohol, unhealthy diet, physical inactivity, and stress. And the most important thing about lifestyle, and therefore the context of discussing the body and mind, is that while genes load the gun, it's lifestyle that pulls the trigger. And therefore, there is a lot of scope to address lifestyle. I heard the last, last few lines of, for example, using yoga as a way of addressing several disorders. And I think so. Lifestyle, in addition to practices like yoga or meditation, are very, very important things that can modify our risks and our recovery from a variety of NCDs. So, we already discussed that cardiovascular disease, chronic respiratory disease, cancer, and diabetes are the commonly recognized NCDs. And now, in fact, India was one of the countries which actually put forth the idea that mental disorders are equally an important NCD. And in the soil that you see here, a host of factors contribute to the risk of NCDs. The important thing to understand is that a whole lot of risk factors can occur together. And when there are more risk factors, the greater is the complication. And we know that demographics like age, poverty, gender, illiteracy particularly, as well as occupation, can be contributing to the other risk factors that are common for all NCDs. The biological factors are something that we mentioned, the family history, age, and gender. But there are a whole lot of physiological factors like being overweight or obese, having a high blood pressure, raised blood glucose, and cholesterol, which we know are important factors. The behavioral factors I've already discussed. And environmental factors, apart from air pollution, also include the addition of food preservatives and adulterants, indoor smoking, which also contributes to the air pollution. And all these are risk factors. So in some ways, our responsibility to patients is not just to treat the disease, but to also make sure that whatever upstream events that were responsible for the condition of the disease are also addressed so that the person can regain at the optimal health that is possible in terms of the future after the recovery from the particular disorder. So tobacco use is not something that I need to talk to physicians about. We all know that tobacco use has a series of complications, but the most important thing is to ask every patient that we see about tobacco use, both smoking and smokeless tobacco use, advise them not to use tobacco in any form, tell them about the risk, but most importantly, tell them about the benefits of quitting and support them in the quitting. It's very well recognized that a sizable number of physicians, while they advise people to stop, do not actively support patients to stop. This is also a very, very important part of the intervention. So one of the simplest ways of actually telling people about tobacco quitting is really to discuss the balance sheet of what are the advantages of using tobacco, because people won't use it if there is no advantage. The advantage might be to relax, to kind of unwind, to reduce stress, etc. But when they understand that the benefits far outweigh the problems with tobacco use, they would be in a position to be motivated to give up tobacco. And if you help them with interventions to stop tobacco use, you can get a lot of benefits. So people talk traditionally about the 5 A's. You can also use the 3A method, which is to ask everybody, assist them in their quit attempt and arrange them. There are behavioral ways of counseling to help them to quit. There are pharmacological ways like NRT and non-NRT medication, which can be used. And of course, engaging the family in our context, involving the community, and making people aware of the facilities that are available both in the public as well as in the private spheres is important. We need to expand those facilities. We also need to be aware of legal interventions like the COTPA, which prevents people from smoking in public places and therefore discourages the use of tobacco in the public space. Similarly, we know that alcohol has a lot of problems from head to toe. We also know that even moderate alcohol consumption can aggravate certain disease conditions. There are a lot of myths and misconceptions about alcohol use, and therefore it's very important, in fact, for people to know about it. In fact, the American Cardiological Association currently says that it's not a good idea to tell people that moderate drinking is good, something that the people were doing in the past. We now know, particularly in India, that any level of alcohol consumption has a linear effect on people's health, and therefore people need to be aware of alcohol use and the way it can impact the disease condition. So the simple way that people can use is a traffic light approach. For a person who doesn't use alcohol or tobacco, just educate them about the consequences and tell them not to use it. For people who are at risk of have been using it and are at risk, you need to do a brief counseling and referral if necessary. And for a person who has dependence either to alcohol or tobacco, they may need a little bit more specialized intervention, and a referral to the appropriate source is important. To be able to refer, one needs to know where these services are available, or simply one can also be trained in developing these services and offer these services. So we also know about diet. There are standard guidelines. We now know that it's better to have a developmental perspective to treating people, because different age groups need different kinds of intervention. And for example, the nutritional needs obviously need to be tied up with the background of the individual. We also have the dual problem of undernutrition as well as overweight in our country. We know that both of these are associated with a variety of disorders, and we need to be able to address these disorders. We know the definitions in our country in terms of what constitutes underweight, overweight, and normal weight, and what kind of dietary counseling needs to be given. And that's something we need to routinely practice in clinical care. The importance of exercise is something we all know, and COVID again taught us that we need to figure out how can we exercise even when there are limitations and barriers to exercising. We know the advantages of both moderate as well as vigorous physical activity, and how much we need to do in a week's time. And it's very important to tell patients about how they can do physical activity, particularly with respect to gender. There are a lot of barriers to carrying out physical activity, and that's something that we need to tell people. So as I mentioned, there are lots of barriers to physical activity, and therefore, as physicians, we need to spend a little time to tell people about the importance and the ways people can make sure that they have enough physical activity within the restrictions that they have. We know that type 2 diabetes, for example, can be reasonably well controlled through physical activity, because that improves the control of blood glucose. We know that active physical activity appears to have a role even in reducing the risk for breast cancer, in coronary artery disease, and in the risk for stroke. And therefore, it is very, very good value that simple interventions can have such great benefits in intervention. We also know the problems of indoor air pollution, although these are probably more when people use combustion products, but certainly they have a huge consequence in various organs in the body. Therefore, we need to look at measures to reduce indoor air pollution, both simple measures as well as policy measures to do so. And of course, we know I need to just emphasize in the latter part of my presentation on the fact that mental disorders, 1 in 10 people or even 1 in 7 people has a diagnosable mental disorder, and anxiety disorders, depressive disorders, and substance use disorders are common disorders that we see in the community and need intervention. We also know that stress itself, not just having a diagnosable mental disorder, but too much stress can also be problematic. While optimal stress is good for everybody, the complete absence of stress or too much stress are both problems that people can have. We also know that stress can also affect our immunological conditions, and a wide variety of NCDs can be aggravated because of stress. And that's very important to understand and intervene for, so that people learn how to reduce stress to improve recovery from physical illness. The corollary is also true, that people who have chronic diseases are more likely to have higher levels of anxiety, depression, and stress. So addressing both makes huge value in terms of looking at people, both because of the immune effects that they can have, the reliance, the adherence to medication that can occur, and therefore this is a vicious cycle which can increase vulnerability to infection and therefore needs to be addressed. I won't go into the common symptoms of depression and anxiety. I think these are things that people know about, but situational symptoms that remit with the reduction in stress need not be considered these. If these persist, for example, depression, if it persists for a couple of weeks, or anxiety, if it is recurrent and the person is not able to, kind of deal with it, even when the situation abates, these are conditions that one must be able to recognize and intervene for. We also know what are the ways of healthy coping and unhealthy coping, which are emotional triggers, lack of sleep, excessive use of alcohol and tobacco, overeating, and not exercising are unhealthy ways of coping, which people must know about. Now, in the last 5 minutes, I'll talk to you about telehealth and how it's really expanded in our country. We now know that more than 80% of the population has access to a phone. M-cessation is something that has been initiated by the government of India, which gives people messages so that they can control their use of tobacco, for example. Similar M-cessation is available for the elder health, as well as for diabetes in other parts of the world. We know that particularly during COVID, e-Sanjeevani has been able to address people who cannot immediately seek in-person physical care. And this is something that the government is looking to expanding. A variety of helplines are available for a variety of conditions, including mental health conditions and suicide. We need to strengthen these. We have a lot of teletraining programs, and the ECHO model of teletraining is one such program which has been used not only in mental health, but also in cancer, in diabetes, in hepatitis, and several other conditions. At NIMHANS, we have established the NIMHANS Digital Academy, which looks at training and accrediting doctors who are not professionals in mental health so that they can intervene and help people, particularly in remote and underserved areas. So there is a huge potential for using, telehealth in reaching people. And in India now, as you know, the Minister for Finance announced in this budget that there would be a telemental health program, which looks at a telephonic facility being available. We actually carried out what is called the psychosocial helpline during the COVID pandemic, and we had received more than 6 lakh calls from a variety of people from different walks of life, and they got a lot of benefit from this. There is a huge treatment gap for mental disorders, upwards of 75%, and people, particularly in rural and remote parts of the country, don't get any form of mental health care. So the whole idea is to, in every state and union territory, have a telemental health facility which is mentored by a specialist institution where a trained counselor can triage the patient, can give some brief advice, refer them to the appropriate services or the mental health specialist wherever necessary. And because some of the mental disorders are chronic, that it is connected up to the community healthcare workers so that the loop is complete and that patients can get ongoing care and be motivated to continue with their treatment. The operational structure is that NIMHANS in Bangalore will operate at the Apex Center. There will be a national technical advisory group, and there will be networks with both the public as well as the private sector in every state and union territory, so that the inequity in mental health care is somewhat equalized by having these facilities as tele-facilities. We hope to include this with the, integrate this with the e-Sanjeevani program, with the Ayushman Bharat digital mission, which talks about establishing health and wellness centers in several districts of the country, in all the districts of the country, in fact. And therefore, there is scope now for integrating mental health and physical health. So in summary, what I want to mention is that NCDs not only include chronic physical diseases, but mental diseases as well. It's important to integrate both physical and mental disorders. COVID has taught us the importance of integrating mental health interventions, not just in illness, but also mental health promotion. And it's therefore very important to look at the body and the mind together and see how our in-person services, our community services can be complemented with tele-services. The first step would be obviously to tell people to look after their physical and mental health and empower them to do so. The second one is to help them to recognize when they need to get help. The third one is to make help available. The fourth one is to provide interventions and rehabilitation and ensure that people's health comes back to as good health is possible, and you have good health to prevent a worsening of the disease condition. I'll just leave you with these ideas. I want to thank the organizers, particularly Sanjay Phadke and Shivrama, for inviting me to this discussion. And I hope the Synapse will be a very exciting and engaging day for all of you to learn newer and newer things and use them in the patients that you see. Thank you very much.
That's been an indeed very inspiring 20 minutes. Madam Pratima Murthy has explained to us the enormous burden of the non-communicable disorders, also the importance and methods of supporting the patient and actually intervening by illustrating through the examples of interventions in substance abuse. And most of all, we have heard a lot about telehealth, telemedicine, and Madam has explained to us the actual way that it is going to be implemented, which I think is very important for us to understand at this point of time. So we also can participate in this big movement of telemedicine. Thank you, Madam.
Hey, Vani, it's lovely to see you. I was so excited to see you in person. Lovely.
Madam is my idol and mentor and primary attachment figure in my professional and special relationship. Thank you, ma'am.
Thank you, Vani.
Now we have our next keynote address by Dr. Sanjay Khalid, sir. Can I have his CV slide, please? So I have a special introduction for Dr. Sanjay Khalid, sir. He's been a very dynamic ESI president that we have seen in a couple of years behind, and he's been our strong supporter of mind-body medicine. And he's been very encouraging enough to start this initiative of Synapse. And it wouldn't have been for his help otherwise that we would begin this moment that we have started. So special thanks to Dr. Kalra. He is DM endocrinologist from AIMS, and he's consultant and head Bharati Research Institute of Diabetes and Endocrinology at Karnal, India. He's been the past president of Endocrine Society. Currently, he's the vice president of the South Asian Federation of Endocrine Societies. He's education editor of International Society of Endocrinology and has numerous publications and book chapters to his credit. So can we have Dr. Kalrasa's presentation, please?
Good day, friends. It's always been a pleasure, part of this great audience from Pune and around. And today, please allow me to speak about a topic that is something very close to my heart. That is actually something that is integral to all our hearts. But unfortunately, something that we've never spoken about before. So let's talk today about autonomic hygiene and how autonomic hygiene relates to diabetes care. Thanks to Dr.vaishalideshmukh for having helped me learn more in this journey of understanding, in this journey of diabetes care. Now, success has many fathers and diabetes has many definitions. The definition that I am most fond of is that diabetes is a state of carbohydrate intolerance. But this is not the definition that is used by the American Diabetes Association. They have a much longer, more complex definition. Some people say that diabetes is a state of hyperglycemia. Others say it is a state of cardiovascular ill health. And many times, at least if you were to ask our patients, they would think we are like the 6 blind men of Hindustan, just searching around roaming around in search of a definition and also in search of a treatment. But please allow me to say that diabetes is an autonomic disease. Hyperglycemia is the manifestation that we see, is the manifestation that we measure, is the manifestation that we chase as a mirage trying to treat. But actually, diabetes is an autonomic disease because it is caused by counter-regulatory hormones. These include autonomic molecules or neurotransmitters. Its clinical features include autonomic neuropathy. It can coexist with comorbid conditions like depression and adrenal disease, both of which are related to autonomic dysfunction. The concerns that our patients come up with can be related to autonomic ill health, like diabetes distress, or autonomic overreaction like hypoglycemia. In fact, the autonomic nervous system also lends itself to control and care of diabetes. When we use bromocriptine, when we try to help the patient relax in his or her lifestyle and mind style, this is autonomic modulation. And if you look at all the conmeds that are used in diabetes and its complications, whether using an alpha blocker, a beta blocker, an ARNI, a RAS blocker, all these are also related to autonomic disease and autonomic ill health. So therefore, we do agree that diabetes is an autonomic disease. It is a disease of dysautonomia. Dysautonomia is everywhere. It's everywhere around us. At the micro level, within our brains, within our bodies, there is disturbed counter-regulation. So the autonomic nervous system is not able to function in an optimal, in a balanced manner. At the meso level, as a community, we all seem to have developed an adrenergic mindset, running after a very elusive target. And this hyperadrenergism, it may be good for a 100-meter sprint, but for the marathon that life is, that human life is, this is counterproductive. And at the macro level, our entire environment seems to have become dysautonomic. If you look at the environment, the kind of food that we eat, the kind of healthcare facilities that we have, or the kind of facilities that we have for physical activity, everywhere you will see a lot of dysautonomia. And in this situation of dysautonomia, when two elephants fight, it is the beta cell that suffers. So in the islet of Langerhans, you see the alpha cell and the beta cell fighting each other in a person with diabetes. In a normal, healthy individual, the alpha cell and beta cell live in peaceful coexistence. But in a person with insulin resistance, first the beta cell begins to work harder. Then the alpha cell begins to work even harder. The beta cell says, if the alpha cell can produce so much glucagon, then I just have to produce more insulin. So it begins to work harder. Both of them don't realize, the alpha and beta cell, that sooner or later they are going to just get tired. They are going to get conked off. So in a normal healthy individual, what was peaceful coexistence in a person with diabetes turns into overwork, overstress, and final failure, exhaustion and failure. In diabetes care, we try to de-stress, de-stress this islet of Langerhans. And that is the crux of using maybe incretin-based therapy or perhaps SGLT2 inhibitors also. It is also the crux of weight loss as a therapeutic tool in type 2 diabetes. But it's not just glucagon and insulin that are fighting each other. If on one side there is insulin, on the other side there is glucagon, so many autonomic neurotransmitters jump into the fray. And these also take the side of usually glucagon. So in a person with type 2 diabetes and cardiovascular disease, you will find that adrenaline, noradrenaline, dopamine from the brain, the renin-angiotensin system, and also hormones like neprilysin and DLP all begin to get increased. It is difficult for them to remain neutral in a diabetic landscape. And that is why we say that diabetes is actually dysautonomia. How do you feel the pulse of diabetes? In a person with diabetes and cardiac autonomic neuropathy, the first manifestation will be loss of heart rate variability, followed by tachycardia. Remember these 2 points, and this single slide now has suddenly helped us put a finger to our own pulse as an individual. What is my loss of heart rate variability? I do not remember the last time I checked. Do I have tachycardia? I am sure I don't. But when I used to go to the gym regularly, my pulse was certainly lower than what it is now. Do I have autonomic balance? How do I answer this question if I cannot even answer this simple question about my heart rate variability? But this I do know, that if I can measure autonomic balance, I can use it as a threshold for risk stratification, as a tool to decide the appropriate therapy, as a technique to monitor my intervention, and also I can use it as a target to be achieved. So when you go to the wise old doctor from alternative medicine who just puts his hands on your pulse, closes his eyes, and feels it for 2 or 3 minutes, perhaps is this what he's trying to find? And is this what he's doing? After 3 minutes, when he tells you, Madam, why don't you take such and such medicine? Why don't you follow this maybe dietary advice? Perhaps this is what he's doing. He's trying to restore autonomic balance to your life. This wisdom is not new. What I am sharing is not out of the box thinking. It is from our old philosophy, our traditional philosophy. The Bhagavad Gita divides people into 3 types: Sattvic, Rajasic, and Tamasic. This is actually a description of the sympathetic parasympathetic fulcrum and its balance and imbalance. Sattvic behavior is autonomic balance, autonomic optimization. Parasympathetic, sympathetic, working in tune with each other, in sync with each other. If you become too adrenergic, too sympathetic, that is Rajasic. And if you let your parasympathetic predominate, that is Tamasic. It is possible that in certain aspects of your life, you are over adrenergic. In others, you are lazy and Tamasic. In yet others, you might be Sattvic. But in general, what I've seen is that when you try to work on yourself, on your autonomic hygiene, and you try to aim for Sattvikta, then you are actually able to impact not only each and every domain of your own personality, but also of the people around you, the people whom you care for, your family members, your colleagues at work, your friends, your seniors and juniors. You are actually able to spread whatever behavior you want. All these personalities, Sattvic, Rajasic, Tamasic, they are all very contagious. Just think about it. When you're in a Sattvic person's company, you yourself become Sattvic. And if you live with Rajasic personalities, you will become slightly more Rajasic yourself. So once again, Sattvic, Rajasic, Tamasic is something that you can use as a model to help diagnose, to help label, to help stratify the risk and behavior, and also to help you decide what kind of therapy you will use, what kind of interventions you will try, and what kind of target you want. And to this is what we give the name autonomic hygiene. Hygiene is defined as, by the WHO, the conditions and practices that help to maintain health and prevent disease spread. So autonomic hygiene is conditions and practices that help to maintain autonomic nervous system health and prevent the development and spread of autonomic neuropathy and its complications. And not only autonomic neuropathy per se, but also autonomic neuropathy that is associated with diabetes. In fact, these are so interlinked that I now feel that the treatment of diabetes as a first line is autonomic hygiene. What is autonomic hygiene? Finding the conditions and practices that maintain ANS health. If I can maintain ANS health, then I will be able to manage diabetes. How do I ensure that ANS health is good? First, I have to be aware of myself. How is my autonomic nervous system functioning? I work to strengthen the vagal tone and I work to suppress the adrenergic tone. Why have I used these lines? Because if you remember, the first line of symptoms for autonomic neuropathy was tachycardia, loss of heart rate variability. So I need to reduce the tachycardia, bring it down into a normal zone. How will I use autonomic hygiene in treating diabetes? Number one, in my lifestyle, in what I do. Number two, in my mind style, in what I think. And I would like to credit and thank Dr. Vaishalideshmukh once again for having taught me this word, mind style. Mind style is very different from mindset. Lifestyle and mind style on one hand, but even for medication, what medication to choose, what not to choose, autonomic hygiene helps. So how can I strengthen vagal tone? By breathing exercises, meditation, yoga, slow and steady aerobics. We have had workshops yesterday. Those have helped us. How do I suppress adrenergic tone? Avoiding too much salt, avoiding spices. These are very rajasic kind of additives to food. I also avoid unnecessary exposure to artificial light. So daylight savings time is not used in India, but the point we would like to highlight here is that do as much work as you can in normal light. So why not wake up with the sun and try to do minimum activities late night after 10-11 p.m. Avoid hypoglycemia as well. Use drugs that do not cause hypoglycemia because hypoglycemia leads to autonomic dysfunction. And also learn exercises, relaxation exercises and coping skill training. To do this, we follow the 3M strategy as well. So this is another way of paraphrasing what I have just mentioned. Be self-aware and self-optimize yourself. That is, monitor yourself. Try to follow a hygienic mind style. And when you are choosing medication, look at the adjuvant therapy that you have used. Maybe a stress reliever, maybe a beta blocker, alpha blocker, RAS blockade. Just think what is required, what is not required. Remember that GLP-1 receptor agonists can cause tachycardia. Whether it is liraglutide or other drugs, all of them will lead to a heart rate increase of about 3 to 4 per minute. SGLT2 inhibitors may not be the best drug of choice in a person with genitourinary autonomic neuropathy because they increase urinary frequency. So we should be aware of all these factors before choosing therapy. If we understand that now autonomic hygiene is actually part and parcel of diabetes management and diabetes prevention, we can begin introducing the concept autonomic hygiene at every level. Primordial prevention, each and everyone in India, across the world, whether they have risk factors or not, should aim for autonomic hygiene and balance. If there is a risk factor like diabetes, even more important, then primary prevention is required. And if there is diabetes and also autonomic dysfunction, it has already occurred, then autonomic hygiene will do the work of secondary prevention. But even if complications occur, patient had diabetes, patient got autonomic neuropathy, and now patient has got other complications like hypertension, heart failure, even then autonomic hygiene is more important. It is just that drugs will be used to ensure autonomic hygiene. This is tertiary prevention. So the drugs that you can use, whether you are using ARNI for heart failure or SGLT2 inhibitor, all of these actually work on autonomic hygiene. Autonomic hygiene, therefore, is just another name for health. That is all it is. It is as simple as that. It's just that we have to go opposite sometimes. You know, Tariq Mehta ka ulta chashma. So let's go opposite, and instead of AEIOU, let's do UOIEA. U is for understand your mind and your body. Health is O for open the doors of opportunity for your health. I for internalize autonomic hygiene. This will help you. E for enhance your health behavior. And do remember to keep on A for auditing and assessing your autonomic health regularly. If you can do this, understand that autonomic hygiene is just another name for health, and do the UOIEA process with us every day, I'm sure we will become more hygienic, more autonomically hygienic, and we will automatically become more healthy. If we can share this concept with our colleagues, with our friends, with the public at large, you will find very good feedback. You will find that a virtuous cycle of hygiene will be created. In terms of pathophysiology, then people don't feel comfortable. But once you begin to own this space, hygiene, autonomic hygiene, and to those who believe in philosophy, when you talk to them that this is exactly something that was written in scriptures like Bhagavad Gita so many thousands of years ago. It is just that they use the word sattvic, rajasic, tamasic, and we are using the English word autonomic hygiene. But it is exactly the same. Then you will find that people will begin to trust you. They will not only trust you and what you are saying about non-pharmacological therapy, they will also trust you when you prescribe an insulin, when you prescribe a glucose-lowering drug, when you prescribe a drug that is cardiovascular safe or which is renal beneficial. And you will find that you will end up with better health, not only in yourself, not only in your clinic, but better health across our great country. Thank you and Jai Hind.
Thank you, Dr. Kalra, sir. I think that was a very new concept. And what we are relating today and understanding through this is that mind body medicine is one of the techniques to help the autonomic hygiene. That is what we can interpret from these talks. And I'm sure that we will take this message ahead to our colleagues and friends and also the physicians practicing diabetes. So now we move on to the next keynote. Dr. Yajnik sir. Uh, Yajnik sir has also been my teacher. It's a privilege to introduce him. He is the professor and director of diabetes unit at KM Hospital and Research Center, Pune. He is a professor adjunct at ISER Pune, visiting professor in molecular medicine at Exeter, UK, visiting professor Danish Diabetes Academy. He is known as a global researcher with special interest in his intrauterine programming of diabetes and vitamin B12 and 1-carbon metabolism pathway. He has numerous awards to his credit. I think he's got about multiple publications, around 3,303 publications, where he's been first author in nearly 79, an outstanding investigator, World India Diabetes Foundation Award. He is David Parker Medal winner of the International Doha Society 2011. So before we all are excited to hear him, so I would welcome Dr. Yajnik sir for his keynote address.
Thank you, Vaishali. Thank you for the invitation, and thank you for letting me speak on topic of my interest. So welcome everyone. I'm just going to tell you about, so we're going to discuss what's called now developmental origins of health and disease. And within that, we'll also concentrate on fetal programming of neurodevelopment. And as I'm never tired of saying, mine is the only diabetes unit which has mother and baby as a logo. And that is because of our considerable sort of conviction that mother's health influences the health of the child, not only when growing in the uterus, but for the rest of the life. And that is the Dohad concept, that maternal size, her metabolism, nutrition, and other environmental factors operating through the uterine environment influence the genome by a number of epigenetic changes, which in turn affects fetal growth, development, and differentiation, some of which we can catch at birth by measuring different phenotypes or measuring in the cord blood various hormones or molecular markers. And then that process continues in the postnatal life. And finally, as doctors, we are used to looking at either risk factors for diabetes or the morbidity or the mortality. And Dr. Kalra told you about primordial, primary, secondary prevention. So primordial starts somewhere here, and then primary prevention comes later in the life. Programming is a word which has come out of, David Barker popularized it. It's come out of current computer programming ideas. And what we basically thought while developing this idea is that normally the intrauterine and subsequent development is very plastic. So if the environment is good, adequate, then you grow to achieve your genetic potential. If the environment is in some way adverse or restrictive, then that restricts this developmental potential, and you have to compromise. That compromise may be structural, it may be functional, and this might increase vulnerability to disease in later life, and that's called programming. Given the development or the intense development that happens in early part of our life, the windows of vulnerability for programming, and therefore also the windows for or opportunity for correcting the situation are in the pre and peri-conceptional period. So this is when the woman doesn't even know she is pregnant. Then pregnancy itself, lactation. Together, these are called 1000 days, and that's a very popular concept nowadays. But it continues in later life. In puberty, again, there is a spurt of development. And also, we now know that plasticity is maintained even in old age in some tissues to a small extent. And as we saw, genetics and epigenetics governs this. Various exposures which control this are nutrition, metabolism, stress, pollutants, etc. Sometimes it can be multi-generational. Therefore, we have to face effects of what has happened before many generations. But the hope is that it's reversible, and therefore we could do something about it. When we talk of brain, the brain development, intense brain development happens in utero, and the processes which actually are covered are neurons develop, they multiply, they migrate, they branch, they form synapses, then there is apoptosis or reprogramming, and then there is a reorganization and finally myelination. And these are the processes which are shown here in the figure. Subsequently, there is growth of the cortex, gyrification, synaptic arborization, myelination, and neuroplasticity continues in the later life. And this is how brain largely develops in early part of our life, but continues to be plastic later life. And there are various figures. I'm not going to go into detail, but if you look at the head circumference, we achieve almost 2/3 of our adult head circumference in utero. And then subsequently, after 10 years, there is very little growth up to about 18 years. In the initial part, that's in utero and early childhood, sensory pathways develop. Language starts picking up after birth and early childhood. And the higher cognitive functions start early but continue to develop till later in the life. And therefore, that is how also the tests which we use to assess the neurocognitive function are developed. And this is an interesting slide, that brain's ability to change in response to experience progressively decreases. And the amount of effort that is required to make such a change has to be correspondingly more. Therefore, more you do in early life, better it is for the future brain function. And this is again showing through the epigenetic thing, but interesting thing which I have shown here is that one carbon metabolism, which is metabolism of methyl molecule, which is largely governed by dietary B12, folate, B6, B2, and controls the methionine metabolism, is an important aspect of this epigenetic regulation because it regulates DNA methylation. Other thing which I should have put in this slide is that maternal glucose metabolism, and especially derangements of it in pregnancy called pregnancy diabetes, are also important in regulating these growths. And this is a cartoon from the World Mapper site. Usually I show these two in my talks because the talk is based on diabetes as the outcome. And India has a unique position that we are the fattest country for early life undernutrition in the world, which includes low birth weight and undernutrition, at the same time as being one of the capitals of the world for diabetes. What I have added today is for stress and mental health, we are an even fatter country for these two outcomes. And therefore, I am very keen to link these in my research. And you will see what beginning we have done. So this is the model applied to, DOHAD model applied to brain development. And we have, in my department, investigated maternal B12 folate nutrition, and diabetes as determinants of the brain development, and have now assessed brain function in our Pune maternal nutrition cohort in childhood and in now young adults. This is largely because I have an intermediate India Alliance fellow, Dr. Rishikesh Behere, who is a psychiatrist and very interested in this. Rishikesh wrote this review or systematic review of maternal vitamin B12 status during pregnancy and its association with various outcomes. And the high level evidence is there for low birth weight, but importantly for neural tube defects, which is a developmental defect of brain, and moderate level evidence for cognitive function in the child, in addition to metabolic outcomes and other parameters. So that's how we are now saying it's very important to look after maternal B12 nutrition to influence these outcomes. And surprisingly, Diabetes Unit KEM is or has been responsible to conduct the largest neural tube defect study in India. And I'll show it in the next slide how many we studied. But this is because actually we were very interested in role of B12 and folate in this condition. And we know 400 micrograms from before conception is advised to prevent the first occurrence NTD, and 4 mg for prevention of recurrence. That means in a woman who already has history of giving birth to a neural defect child. In India, the tablet of folic acid which is available is 5 mg, and obstetricians use it either 1, 2, 3 per day to prevent even the first occurrence neural tube defect. And given that we have large amount of B12 deficiency in India, we suspect that there could be detrimental effects if there is an imbalance of these two vitamins. And as I told you, in this 4-center study of neural tube defects, which was Pune, Madras, Ahmedabad, and Hyderabad, we studied more than 300 cases of neural tube defects, and we studied 700 controls. The diagnosis of NTD was mostly by antenatal ultrasound. Very few neural tube defects were delivered, mostly in populations which did not have access to ultrasound. And what did we find? Risk of NTD was related to low holo TC levels, which is the active vitamin B12. It was not related to maternal folate concentrations. High maternal homocysteine concentrations was also a risk factor. And in this population, large part of variants of homocysteine came from B12 rather than folate. So these were predominantly vegetarian population. Maternal polymorphism in TCN2 gene, which is for the holo-TC gene, was a strong predictor of neural tube defect in the child. And therefore, we thought we have supported a causal role for B12, maternal B12 status in risk of NTD over and above the established role of folate. And I think this is an important message that we need to supplement B12 in addition to folate or folic acid. In the Pune maternal nutrition study, I'm not going to go into detail, but I started this almost 30 years ago. And first generation mothers were the women who were married but not pregnant. They gave birth to their child, which is F1 generation. Now F1 generation have also become adult and become mothers. And we have more than 200 children born in the F2 generation. Given our results of B12 in the F0 and F1 generation, we did a preconceptional B12 supplementation trial when F1 generation was 17-year-old, so that F2 generation is born in this randomized controlled trial. What were our findings which actually made us do this trial? This is the first finding published many years ago, that low maternal B12 concentration at 28 weeks gestation was actually associated with a longer time taken in the color trail A test. That means their performance was poor. It took them longer to complete the color trail. And this was the initial triggering investigation. After that, we have done number of studies which confirm this either at a younger age or at a later age. Based on that, Dr. Rishikesh actually decided to study structure and function of the brain in relation to exposure to maternal low B12 or high B12 status in pregnancy. And you must understand that because we have a serially followed birth cohort and we have extensive measurements in pregnancy and subsequently, and a very precious biobank which has 3-generation blood samples, we are able to do such studies. So what Dr. Rishikesh actually decided was to do neuropsychological tests in young adults in F1 generation and very detailed MRI measurements of brain, which would include structure, which is volume, cortical thickness, and gyrification index, and in addition, MRI functional connectivity. It's one of the most complete studies of such nature. I doubt if there is any other study in the world where intrauterine exposures to B12 folate have been actually used as exposure for adult brain measurements. And just to give you preliminary results, B12 status of the mother was actually associated with differential development of different parts of brain, which is showed in red spots here. For cortical thickness, this is left brain, this is right brain, and this is gyrification index. Interestingly, folate was not really much selective. It was involved in development of these across the brain. But B12 seems to be quite selective and picks up areas in brain where development occurs. So higher greater cortical thickness in frontal and temporal lobe was driven by B12, and higher maternal B12 drove these things over large frontal and temporal areas. If we look at hippocampus, which is quite an area of interest, partly because its active period of neurogenesis is in the first 200 days since conception, and it is implicated in neuropsychiatric disorders like depression and schizophrenia. Maternal folate was a major sort of driver of the volume of hippocampus at 21, 22 years of age. And then when we looked at interaction between maternal B12 and folate, the first 2 bars are in mothers with low folate concentration. 2 second bars are in mothers with high folate concentration. So a combination of low folate with high B12 also didn't help brain. And a combination of high folate and high B12 actually helped brain development in different areas. In other words, you can't have one or the other. You need to have both. As many of you are aware, both act on the same enzyme, methionine synthase, but folate cannot act unless B12 is there. And this is nicely proved in this figure that the two are required for proper development of different areas of brain. Then coming to the Priya trial, which is what we call in the adolescent trial, the Pune rural intervention in young adolescents. Before COVID stopped our study and we had to do a sort of early assessment of the study, what we found was this is now the 3rd generation on whom brain function was measured between 2 to 4 years of life, and their mothers had either received a placebo, B12 plus multimicronutrient, or B12 alone since they were 17 years old till the time they delivered the child. It went on for 8.5 years. It's world's first preconceptional adolescent intervention trial. to study the outcomes in the next generation. And what we found, B12 alone supplementation always actually perform better for cognitive, motor, as well as language domains between 2 to 4 years of age. And this was significant for cognitive and language, just missed the significance for motor. In other words, a very small dose, 2 micrograms per day, given from much before the girl becomes pregnant, has helped the brain and brain development and its functions in the child. Another aspect is exposure to diabetes in pregnancy, and this study we have recently started, so I'm just going to tell you preliminary thing. This is funded by DST, and what we decided to do was to study the neurocognitive performance in children born in diabetic pregnancies. For that, we use a standardized neuropsychological assessment score. We use a new fancy machine which is called functional near-infrared spectroscopy. And this machine has a helmet like this, which she is putting on her head. She is connected to the computer and she does various sort of tests which are driven by the computer program. This helmet contains various detectors for blood flow determination in different parts of the brain, which you can see in the outputs. So in addition to doing neurocognitive performance tests by questionnaire, we are looking at altered blood flow in different parts of the brain in response to various stimulation tests. And then we also have strength and difficulties questionnaire for these children, in addition to their scholastic performance, etc. What did we find initially? Because of COVID, actually, we had to delay calling them to the department because of the COVID rules. So we did an online survey of their difficulty, higher difficulty and behavioral scores in first 120 participants. I have to tell you that there was a higher rate of pregnancy complications in diabetes pregnancy, like preeclampsia and lower section cesarean rate. There was a higher number of neonatal admissions to the NICU. And on our observation, we found that ODMs, that is offsprings of diabetic mothers, had higher temperamental difficulties and higher difficulties in behavior score assessment compared to the children born in non-diabetic pregnancies. We are currently actively collecting the near-infrared data and the other data. So watch the space and we'll tell you next year how we actually, what our findings are. And this is a preliminary thing to show that there is actually some problem with the brain performance in children born in the diabetic pregnancies. Having said that, I have seen some of the most brilliant children born in diabetic pregnancy. So I'm also interested in testing the idea whether there is a U-shaped association between maternal diabetes and brain development in the child. But for that, we will have to complete the study before I can analyze that result. So in summary, I've shown you that our observational studies suggested that maternal B12 and folate are important for neurocognitive outcomes. We also showed a causal role for B12 in an intervention trial which started preconceptionally. And we have preliminary evidence that babies born in diabetic pregnancies may face neurocognitive problems. All these studies have implication for public health policy. On one hand, we need to ensure a good B12 status of the mother before conception, in addition to giving her the IFA tablets. And we will then have to also think about how to manage pregnancy diabetes to avoid the problems in the diabetic pregnancies. I'm always fond of showing these two slides that we should remember that pregnancy is an experience for the two, and therefore very specially protect the pregnant mothers for actually promoting the well-being of the two individuals. And there is one situation where it's an experience for three. This is a pregnancy with a female child. And as you know, or perhaps you know, that when a woman is pregnant with a female child, that child carries all 1 million ova in its ovary from 20th week onwards gestation. So that at the same time, there is a grandmother here, there is a mother, and there is an F2 generation growing in these ovaries. And therefore, a female child pregnancy is super precious for preventing or primordial prevention of various problems in next 2 generations. So I have to thank my staff who actually all contributed to this, but importantly, Rishikesh, who has conducted many of these studies, and his mentor, Dr. Gopi Krishna Deshpande from Auburn University in Alabama, USA, who is an expert on interpreting MRI for structural and functional differences. Thank you very much. And these are our funding partners across years. There are many from India and even more from abroad. Thank you.
Thank you, sir. Thank you for the sharing your experience and taking through the journey of your work. And we look forward to many more studies from your center next year. We'll get some more data from your side.